Hello, I'm Ursula Marinelli. I'm the Executive Director of the Pacific Communities Health District Foundation in Newport and the Interim Director of the North Lincoln Hospital Foundation in Lincoln City. Welcome to What's Inside, a closer look at diagnostic imaging with Tommy Williams. Tommy is the Diagnostic Imaging Manager at both Samaritan Pacific Communities and North Lincoln Hospitals. Samaritan Foundation MedTalks are conversations between employees and community members to help you get to know us and our services a little bit better. Today's MedTalk is presented by The Human Bean, a Samaritan Foundation's Pride partner. MedTalks are meant to be interactive, so please feel free to ask questions by raising your hand with the hand icon at the top of your screen or by typing your question into the chat. If you're on the phone, you'll just have to verbally ask your question when there's a break in the conversation. And of course, if you're not speaking, please remember to mute. And if you're called on, please remember to unmute. So are there any questions about any of that? Okay. Well, Tommy is here, and so I am going to turn it over to him and let him start by just telling us a little bit about himself. So go ahead, Tommy. And you need to unmute.
Please choose carefully from the following options as our menu has changed.
Okay, so I started in Memphis, Tennessee, radiology program at Baptist Hospital, which was it was in 1980. Got out in 1982. Went to nuclear medicine school in 1983. Same program. Baptist Hospital at the time was the largest private hospital in the world at 1,750 beds. So it was a good place to cut your teeth and a good place to learn about medical imaging from some of the best people in the country at the time. We had world-class physicists that taught us radium physics. We had high-level educators in both radiographic technique and positioning, anatomy and physiology. So it was a great program, and still today it's probably one of the best in the country. Once I got out of nuclear medicine school, I transitioned into nursing school at St. Joseph's Hospital in Memphis, Tennessee. So I'm actually a nurse as well. So I have I'm a hybrid in this field. It's changed a lot since I got in. Everything when I began was cut film. We used various size cassettes. There were different cassettes for different organ processes. We had what they called 200 speed, 400 speed, cardboard. We had rare earth that we used for body imaging. CT was in its infancy. I've actually scanned on every generation of CT scanner made, starting with the EMI head scanner that was developed over in Europe, all the way through the technology today, which is multi-row and single source detectors. So I've literally seen pretty much all of it from the beginning of time to where we are now.
Tommy, I know that you had mentioned when we talked that the changes you've seen are actually mind-blowing. Those are the words you used. Can you talk a little bit more about that, and also how the patient has benefited from those changes over history?
Well, when I started, like I said, we had two methods of developing X-ray film. You had the automatic processors, and they ranged anywhere from a 90-second development time all the way up to 5 minutes, depending on what type of equipment you had. We also still hand developed in the OR, meaning that we actually would go into a big room full of chemicals and with a dull red light, and would actually dip X-ray film into a tank and sort of do this until you started to see an image, and once it looked the way you wanted it to look, you stuck it in the fixer, wiggled it around, and then rinsed it, and then ran it back to the OR suite for the surgeon to look at. So today we use digital detectors, which are made up of several different photoluminescent organic chemicals. And processing is instant, meaning that the minute you hit the exposure button and the X-ray actually penetrates the patient, the image appears on the screen, and you can literally turn it into whatever you want. You can mask it, you can flip it, you can invert the image, going from white bone to black bone. You can change the contrast, you can change the scale of gray. So in a way, X-ray today is infinitely easier than it was when I started. Everything that we used back when I started school was predicated on you understanding what kilovoltage did to an image, what milliamperage did to an image, and what time did for an image. That was called radiographic technique. You had to know that, learn it. It's high-level math. You also had to understand radium physics and what different parts of the body did to X-ray absorption. And the techniques that you set to get an image were manual, meaning that you had to know in your head, based on what the patient looked like, how big they were, what type of physical condition they were in. You had to actually pull up a technique that would not only penetrate the patient, but would give you what we call a diagnostic image. So all that's pretty much out the window. You have phototimers now that actually sense when a body part's been penetrated, and then the image flips up on the screen, and you make it look really, really pretty, and you just ship it on to the radiologist. They read it, and then you're on your way. So I would say the biggest difference between old school and new school is we considered it an art back in the day, because you had to actually understand math and physics and geometry. And today, a lot of that, I'd say 75% of it, you don't really need to understand in the way that we understood it a long time ago. We used, the inverse square law consistently back in the day, depending on what distance we were shooting an X-ray at. And if you knew how to manipulate that formula, you knew how to adjust your technique from 36 to 40 inches to 72 inches. And you don't have to know that anymore. The machine figures it out for you. So
right,
I probably sound like a completely old, dogger, but I mean, it's just a completely different science than it was when I first entered the program.
And what would you say has been the primary implication for patients in terms of their experience?
Well, the exams go much quicker. The actual X-ray that you have to use, the amount of power that you have to use, is significantly reduced. I'd say the techniques we used in orthopedics, where you used cardboard cassettes, where you wanted a lot of bone detail, the X-ray exposure today is probably 70% less to get a good diagnostic image than it was back in 1980.
So a lot less radiation.
Yeah, typically when we moved from cut film to computerized radiography, which was CR, it reduced the dose anywhere from 30 to 50%, depending on what you were imaging. Today, going from CR to DR, that's now somewhere between 50 and 70%, depending on what you're imaging. I still will say the one thing that exposure has increased is in CT. And probably the biggest misnomer about CT is, yes, it produces a lot of radiation, but the fact that the machines are so sophisticated, that beam is so concentrated now that the actual peripheral exposure on the CT scanner is probably 75 times less than it used to be with the probably the second, third, and fourth generation scanners.
So then, speaking of CT scanners, would you just talk about what kinds of diagnostic imaging technology we have here on the coast at the two hospitals?
We have really high, we have some of the best equipment not just on the coast, but I would say in the state of Oregon. Both hospitals are relatively new. The equipment inside these hospitals is as advanced as you could buy when the hospitals were finished. So the technology here is on the cutting edge. Our CT scanners at both Newport and North Lincoln can literally do any type of work that you'll get in Portland or Seattle or San Francisco or Los Angeles. They are that good. But to complement that, the personnel that we have in the building, both on the CT, MR, and ultrasound end, they work at a very high level. And the fact that we're tied to Corvallis Radiology, their radiologists expect us to produce the same quality of work that you'd see anywhere else at a large metropolitan hospital. So everybody that does what we call a special modality like CT is licensed in CT. Our folks that do MR are licensed in MR. The sonographers are ARDMS certified, and they carry several subspecialty licenses. So from a personnel perspective, we're as good as anybody. I came from Emmanuel Medical Center in Portland, and the folks we have on the coast are just as good as anybody that you would find there. As far as their skill level, their ability to manipulate equipment and make it work the way you want it to work, and the fact that they understand pathophysiology, they understand X-ray physics, just makes it, they just are able to work at a ridiculously high clinical level.
Great. It looks like we have a question from Lucy. You want to go ahead and ask your question, Lucy?
I can't.
Yeah, if you're speaking, you're probably muted.
I am. Are you in Newport or Lincoln City?
I manage both campuses.
Okay, because I just got a message from Newport that I'm supposed to call about some imaging. I'm just getting started on my cancer journey. I had to go to Corvallis to get a PET scan. Is that coming to the coast at some time?
We do have PET services in Lincoln City. It's a mobile service, and it is the service that's run out of Albany. So you can actually get your PET work done in Lincoln City.
Okay. And then I'm wondering, it said that I had a PET/CT.
Right.
They're not the same thing though, are they?
They're not the same thing, but they are the same machine. That is a nuclear medicine machine that actually is half gamma camera, half CT scanner. It's a hybrid.
Okay.
And what it does is it takes the nuclear image, and then it will take the CT, and they will overlap the images.
Oh.
So you actually get a layered exam. It's very effective.
Well, I know they found all kinds of things that I had no idea I had.
It's difficult for anything to hide on a PET scan.
Yeah. Okay, thank you.
Yes, ma'am.
Okay.
And just, I guess, one thing I should say, I'm easy to find. So if you call imaging at either hospital and you have an issue or a problem or even a question, they can send you to either phone extension, and you can be certain I'll get back with you.
Great, thank you.
Yes, ma'am.
Thank you, Tommy. Would you talk? Oh, it looks like Juliana has a question. Go ahead, Juliana. Go ahead and unmute.
Okay, you can hear me now?
Yes.
Great. So my question is, aside from having, I'm assuming, different people with subspecialties, is there any reason why, like if you're doing a follow-up on an ultrasound for a breast cancer, why you couldn't go in for at the same appointment to do a follow-up on, let's say, a thyroid lesion in the same, at the same appointment?
It depends on the radiologist that's in the building at the time. Most of the women's imaging, when biopsies and ultrasounds and a mammogram sort of, tandem together, usually we have access to a women's health radiologist in those situations. Thyroid biopsies, anything that's labeled as interventional, usually we wait till there's an interventional doctor on either campus to do those procedural type exams.
Okay, thank you.
Does that make sense?
Yes, that makes sense.
Okay, great. So you had described the PET CT scanner. Oh, it looks like we have another question. Linda, go ahead, Linda, and ask your question. And
I'm
unmute.
wondering if you could help the lay people here, like me, understand the difference between a CT scan, an MRI, an ultrasound, an X-ray, and a PET scan, and where they would be appropriate to be used?
Okay. Well, MRI uses naturally a large magnet, and I could go into, for me to explain to how MR works, that's some pretty weighty physics. So what I'm going to do is I'm going to focus on the fact that MRI is more of a soft tissue modality. It's very good at MSK. It's very good at neurology work, brain, spinal cord. We use MRI for spine injuries, hip injuries, knees, ankles, elbows, you name it. In the last MR body imaging has gotten very popular, especially when it comes to gallbladder and liver disease. So we discussed a little bit about PET and CT. PET imaging uses beta energy, radioactive material that's injected into your body. The camera actually picks up that radioactivity off of your body. That's how we glean an image on the nuclear medicine side. The CT portion basically does axial imaging from head to toe, and those images are typically overlapped. CT is probably the most universal modality, meaning that it can do bone work, it can do MSK work, it can do body work, it does angiography work, blood vessels. So an X-ray is just.
Tommy, I'm sorry. What does MSK stand for?
Musculoskeletal. So it can do, CT can do, CT today is like basic X-ray was in 1980, meaning that it has a universal application. It's used usually as a second step exam for specificity, meaning trying to dial into a problem. X-ray is still what we call base X-ray. Those are chest X-rays, long bones, femurs, tibias, ankles, hands, feet. Usually that's just for base fractures. Ultrasound is very specific for, it is what it says it is. They use sound waves to generate images. Its primary applications now are OB, abdominal imaging. They do a lot of interventional work with ultrasound guidance, especially when it comes to fluid in the belly, fluid on the lungs. Most thyroid biopsies are done via ultrasound guidance. Most of the breast work now is done under ultrasound guidance. They do a lot of vascular work. They do carotid arteries in the neck. They do arterial and vascular work in both arms, legs, feet. We do a lot of ultrasound work for abscesses, for wounds that don't heal.
Tommy, there are a few questions in the chat that I thought I would just ask. So if I could, Luke asked a question about what are the number of slices that are available at both coastal CT machines?
They're 80.
Both are 80. Okay.
Both are 80. Basically, they're 64 slice scanners, but they're configured in a way where they can produce an 80 slice image. And that's one of the things that you see a lot of in CT now to try to reduce the cost of equipment. You'll see 64s that can emulate a 128 scanner. You'll see 128s that can now emulate a 256. A 256 cannot emulate a single source detector scanner, but to bring the cost of the unit down, and that's why you see a lot more sophisticated equipment in smaller hospitals today than you used to. It's because it doesn't cost that much more to bump a 64 to, a 128 or a 128 to 256, because basically it's software, it's smoke and mirrors.
Okay, thank you. Another question that John has is how much more accurate is the new imaging equipment at finding abnormalities?
Oh my goodness, I would say it's incalculable. I mean, you can't calculate it. It's so, if I could show you what a CT scan looked back like in 1982, just an axial body image, and what one looks like today, you would think the one in 1982 was hand drawn. Just think about what your TVs look like. That's the best way to parallel what's going on in imaging. The first HD TV you got, the picture was really good coming from a standard tube TV. But when you went to an Ultra HD TV, you thought, well, I can't believe I had to watch, that in standard def. I mean, it's that different. Some of the most remarkable work as far as diagnosing and treating disease, those advances have come in MR, they've come in PET CT, and they've come in what we call true interventional imaging, which, that's the high level stuff that's done on places that do intracranial neuro work, open heart chest, that sort of thing. Those pieces of equipment are light years ahead of what I worked on early in the day when I was working as both an X-ray tech and a nurse in a cath lab.
Interesting, thank you. Another question that Mary Jo asked is whether patients can request which location they choose for a DI service, for a diagnostic imaging service. Can they choose Newport, Lincoln City, or Corvallis?
They can. Usually the doctor or the referrer, they're the ones that decide that. I know that there are things that we do in Newport that they don't do in Lincoln City. So there are cases where, to keep somebody from having to drive to Albany or Corvallis, the patient will go from Lincoln City to Newport, or Newport to Lincoln City in the case of PET CT. The one thing I will tell you, there are insurance companies and carriers that will off by location, so you have to be careful. Make sure that, let's say a doctor orders a CT of the abdomen, and because he's tied mainly to Newport, it may be off for Newport. So if you want to have it done in Lincoln City, before they start that authorization process, just tell them, hey, I want to go to Lincoln City to have this done. The order goes to Lincoln City, and we take care of it there. The authorization problem is something that you just have to watch if you want to switch location. And many times, if we know that the patient wants, let's say somebody calls our scheduling office and says, hey, the doctor wanted me to have a CT in Lincoln City, I want to have it in Newport, we'll look at the auth, and if the auth is specific to Lincoln City, we'll contact them to flip the location.
So it'll be important for them to just say ahead of time or early in the process where they.
Yeah, if they
like
tell you they want to order a test, just say, hey, by the way, I want to do it here.
All right, and then the last question currently in the chat is, could you talk a little bit about a HIDA test? HIDA test?
HIDA, yeah, it's a hepatobiliary test. It's a nuclear medicine study. It's relatively pain-free, except for one portion. So basically, it's a nuclear medicine test. It's usually done in a dual head gamma camera. They inject technetium 99M. It's a tech-based radioactive material. It's tagged with a little drug called Colatec that is specific to the liver and biliary system. So they inject it, your liver lights up, and we watch your liver fill. We watch the gallbladder and the duct tree fill, and we figure out how well your gallbladder works. We do it over 90 minutes. About 60 minutes into the study, we give you a slow drip of a drug called Kinavac, which actually makes your gallbladder contract. And that can be a little uncomfortable because it will make patients a little bit nauseated. They will get cramping in their right upper quadrant, right under their diaphragm. But what it allows us to do is take the before images and take a measurement, take after the CCK, take a measurement, and we can tell within 3 to 5% of how well your gallbladder functions. So if that ejection fraction, that difference between one and the other, is below 33%, chances are they're going to yank your gallbladder. Doesn't work anymore.
Tommy, can you talk a little bit about the rest of the equipment that's in the diagnostic imaging area, DEXA and mammography? And I'm not sure if you had covered everything.
We have 3D mammography on both campuses. We have two great leads. We have Sydney Kastner in North Lincoln, who's just wonderful. We have Megan Dillon, who's a lead in Newport. She's just wonderful. They're both very, very good. We've got Patty Harklow that works with Megan in Newport. We've got DR X-ray equipment in both campuses. We have a Siemens Canon mix, and Toshiba now is Canon. Toshiba in the medical field doesn't exist anymore. Canon bought them. So we have a Canon DR unit in Newport. We have a Siemens DR unit that also does fluoro in Newport. We have Siemens DR X-ray in North Lincoln. We have Siemens DR X-ray and fluoro in North Lincoln. We have DEXA units in both locations, but we currently don't have anybody on campus in Lincoln City that does DEXA. So all the DEXA work right now on the coast is being done in Newport.
And can you explain what DEXA is?
DEXA is bone density. It measures how much calcium is in your bones and what your fracture risk is based on the condition of your bones and your age. Another one of those mathematical formulas. If you want to work at X-ray, you really can't sidestep math or physics.
So you started talking a little bit about staffing. You have been talk a little bit about when you joined Samaritan and how staffing has changed. Is it challenging to staff the area, being we're in a rural coastal area?
I think the perception is it's tough. The housing situation on the coast makes it. That's probably the biggest deal breaker when it comes to hiring personnel, from what I've seen. And that is something that I actually filled out a survey on that for HR yesterday. I mean, I guess, is it hard? Yeah, but it's hard everywhere. I don't care what hospital. I mean, in Emmanuel, and because Emmanuel was, it's a level 1 trauma center. You have Randall Children's Hospital. There, you know, there were people that didn't want to work there because of the volume of work and the acuity level of the patients. So it doesn't really matter what facility you're at. If you're not in whoever you're trying to hire's wheelhouse, they're not going to come work for you. We got lucky in Newport. When I got there, they just let the nuclear medicine tech go. That's a really tough find anywhere in the country. So I just made a few phone calls to people that I knew and said, hey, are you interested in this job? So I poached the lead nuclear tech out of Emmanuel and had her come work in Newport. I've done the same thing with a job we're just beginning to fill in Lincoln City. I called a guy in Springfield that's a good x-ray tech and a great CT tech and say, hey, you know, are you interested? So it's all about networking and who you know, and you know, if you're a decent guy or girl and you manage a department and you have a reputation of being, you know, somebody that, you know, is pretty good to work for, you can usually poach personnel that you know from another hospital. So that's what I do. I've taken people consistently out of places that I used to work. Okay. How's that?
Well, we appreciate it.
Yes, we do.
So are there other questions out there, either in the
I'm
chat?
trying to steal a girl right now from Prague, Portland. So, you know, I almost got her. Still working on her.
Mm-hmm. Any other questions for Tommy?
Like I said, I'm easy to find. I mean, I was trained. I mean, even though I was educated in a large metropolitan hospital and some fairly fancy universities, I was trained how to manage and work in rural hospitals out of the Baptist and Methodist systems in Memphis. That was a time where a lot of community hospitals were failing and these bigger hospitals were buying the small hospitals. So they would, you know, if you had, you know, a heartbeat and a little bit of talent, they would throw you into those scenarios to see if you could actually help turn these smaller hospitals around. So I've spent the majority of my career in rural healthcare. I like it. I think it's more personal. I think it makes you more accountable because you can run, you know, you can do a CT on somebody at 3 o'clock in the afternoon and run into them at the grocery store at 6. So you have to be careful. You know, I prefer it. It's a lot, it's a lot more personable. I don't know. I like it a lot.
Great. Dr. Ogden, our CEO, has a question for you. She says, if money and resources were no object, what service, if any, would you add to our coastal hospitals?
If money were no object, you have to be careful. And we're going to go back to the whole rural healthcare thing. And Dr. Ogden may come over here and hit me in the head. But I think the best community hospitals that I've ever worked in are ones that were really good at the basic services. You know, didn't try to get into high-level cardiac, didn't try to get into high-level neuro. So, but one thing I think that we lack on the coast right now, and specific to Lucy's question right out of the gate, I think we probably need a permanent PET CT system, and those are very expensive to install. But given the number of, and I'm speaking from personal experience and the numbers that I see, so this is real, we stage an awful lot of cancer in both facilities on the front end. And I think that's the one piece of equipment that we could position at some point in on one campus and take care of a lot of folks. Because, I mean, I live in Corvallis right now. That's a tough drive on a good day. I can't imagine making that drive when I didn't feel well. So,
Yeah.
I think for money spent, it's probably the one imaging element that we could get into and make a real difference for the folks that we take care of.
Looks like Betsy Bordeaux has a question.
Yes, thank you. Can you please tell me what an MRA neck with, I guess it's without contrast is?
Yeah, that's a, they're looking at the vessels in your neck. MRA without means they're not going to use contrast, so it's a very non-invasive study. It's a very effective study. It's an MR-based application.
Okay, thank you very much.
Yes, ma'am.
Okay. Any other questions for Tommy?
Well, I guess I will ask one. Apparently, several years ago, I had a stimulator thing for overactive bladder, and my doctor wants me to have an MRI. And apparently, there's a problem because of this implant.
It depends. I will tell you that when MR, naturally, any metal in your body, we have to screen, and depending on the age of the stimulator, we have a book and a website that we go on, and we can actually, if you have the serial number and the information on the device, you can give that to our MR tech, and they can research it and see if it's MR safe.
Right.
A lot of implants today are MR safe, but depending on the age of the implant, like people that had stents put in, 15 years ago, a lot of those are no longer, those were not MR safe. So, that's why we vet serial numbers and products before we put somebody in an MR that's had any type of implant whatsoever.
Okay, thank you.
Yes, ma'am.
There's another question in the chat. Could you give an overview of mammography? This person is worried about pain and tissue damage.
Well, I can speak in relative terms to mammography as a guy, because we don't do mammography, but I will tell you that specific to the equipment that we have and the technologists that we have in the building that do mammography, I'd say that the chances of tissue damage are very remote. I mean, Sydney and Megan and Patty, they're experts at what they do, and I would say that as far as from our services, the most of the compliments or handwritten notes that we get from patients are specific to ladies that have come in for mammography, and they're typically complimenting the level of service they received on either the Newport campus or the North Lincoln campus. I mean, they do their best to get the best quality image, because in mammography, positioning and the quality of the work on the back end is everything. If you don't take care of a tissue fold, or you don't visualize the pectoral muscle well versus breast tissue, you can actually cost somebody their life because you're going to miss something. So I know it has to be an uncomfortable exam, but the old saying, they compress because they care, that actually is true. I don't know if that completely answered the question, but I would say that I've only known of less than 10 instances in the last 25 years where we've had a breast tissue injury because of a mammogram.
So Michelle is asking if you can explain how the actual process works. Like what is the actual process? What is the test like?
The mammogram?
What is it to get a mammogram? Yes.
Well, as a guy, I don't know. I will tell you that I can tell you what the views are. You have a craniocaudal and you have what's called a mediolateral. Craniocaudal means that you're going to face the mammo machine, you're going to put a breast down, and they're going to compress it front to back, and they're going to take a couple of pictures. Mediolateral is they're going to shift the position of the machine. They're going to position you, and they're going to take basically an oblique side view of your breast. I can't speak to the discomfort. There is a CT type application with tomosynthesis that gives them a ton of images that they can sort of overlap and make one image out of. So as a guy, I just can't speak to the actual mechanics or discomfort involved in the exam.
Tommy, I'm going to ask Dr. Ogden if Lucy, are you willing to explain?
No, I just had a mammogram a week ago, and it was the least painful one I've ever had.
Nice.
So that's a compliment. Thank you.
Yeah, and I was going to add, I just had mine probably 2 months ago, my yearly, and I've been having yearly ones because of breast cancer risk since age 30. So I have had now a multitude of experiences everywhere from the East Coast to Portland to the coast. And I have never associated pain with a mammogram. I just associated some mild discomfort. I mean, nobody likes to have their breasts squished, between two plates, but it's not particularly painful to most people unless you just are hypersensitive. It's just, and it's something that lasts, it's a super short time period. As soon as they can get the image, get you positioned, you hold your breath, take the image, and then it's done. So, and then of course I would say with our personnel, exactly like Tommy said, I mean, these are ladies who their profession is mammography. This is all they do, is day in and day out take care of patients and get these amazing images in as quickly a period of time as possible, and then with as little discomfort as possible. They're there to just assure a good experience throughout. So I've just never had better service than I don't feel like I've had a better care experience anywhere else either. So now I'm a little prejudiced. I have to say these are my hospitals, but I just most assuredly can say that from lots of experience.
I can add to that. Like Dr. Ogden said, the women that do mammography, it's not a job. The ladies that do mammography, and this is, they believe in it, they understand it, and they want to make a difference. Mammography, I think a lot of times people think it's a fairly easy exam to do. It's not. These are professionals. They understand women's health. The mammography is the most heavily regulated imaging platform that we do. The federal government requires us to be in line. The state of Oregon requires us to be aligned. It's inspected twice a year, every year, like clockwork. And if everything is not perfect, I'm talking about record keeping, image quality, patient satisfaction, you're literally going to be out of the mammo business because the FDA is not going to certify you and the state of Oregon's not going to certify you. It's hard. It is a hard job. And the ladies that do it because they believe in it and they want to make a difference.
And it's worth it to go in and see the bras. You gotta see those bras.
There are some artistic bras hanging in the room where you have the mammogram done. So there's another question from Michelle. What type of imaging is useful in neuropsychology? Are particular types of imaging helpful in determining developmental delays and differences like autism?
Yes, the two areas that, and we don't do either. You have FDG SPECT imaging that's done in nuclear medicine, and that's done at a very high level. Usually you find those on big academic, like Duke. You'll see, I mean, that's a very specific test. One thing that we did a lot of at a manual, because we saw so much brain injury. We also had a children's hospital on campus. We did a lot of functional MR imaging for to diagnose developmentally delayed children, and there was an aspect of autism that was diagnosed that way. So I would say MRI and high-level nuclear medicine for those types of issues.
Okay, Dr. Ogden is asking, can you speak to the regulatory environment in diagnostic imaging?
The regulatory environment. Well, just recently we went through both the FDA MQSA mammography certification program on both campuses, as well as state inspections. Those are rough and rigorous. We also went through X-ray inspection with both the state at both Newport and Lincoln City recently. They look at the health physics on all of our equipment. They look at our fluoroscopic records. That's live fluoro. We have metrics set with every X-ray exam that we do, every fluoro exam we do, where there are exposure limits, and when those exposure limits are breached, we have to investigate and find out why. So the state looks at those records. The state looks at our personal dosimetry readings. Those are the little badges that we wear that detect radiation. They look at our credentials. Are we legal with the national board? Are we in CE compliance with the state boards? They audit. They'll audit our radiologists. They'll ask to see some of those records. The ACR does that routinely. So I guess we're probably watched closer on a state level than we are on a national level when it comes to MR, CT, and ultrasound. But the federal government expects the state to do a good job on that side. We have very little involvement with the federal government when it comes to imaging regulatory compliance. The federal government is heavily involved on the mammography side with the Food and Drug Administration. If you don't have your certification from the FDA, you're not doing mammography. Dr. Ogden, does that answer the question?
Oh yes, I'm just constantly amazed at how complex your world is and how many people are looking over your shoulder to make sure you do everything perfectly. And I certainly didn't have an appreciation for it until I got into this role, and I think it's important that everyone, understand that the all of the regulatory types of standards that are set apply to everyone across the board, and we don't get a break just because we're in a rural area, that we have to meet the exact same criteria and do the exact same things. So people can be assured that the services they get and the equipment that we're using are, you know, the highest grade.
All right, here, I don't know if you guys can see this. This is what they went through just in X-ray and CT back in December, and this is all current. So this is the kind of stuff that you have to keep track of and what you have to put together to stay out of. I mean, Dr. Ogden's going to be pretty upset if the state sends her a fine of $65,000 because we didn't do what we were supposed to do. She's probably going to personally walk me out of the building. So I think sometimes people over exaggerate about record keeping and the documentation that you have to have in place, but that is literally the book that I had to put together at 2 campuses. I mean, that's just for North Lincoln. The one at Newport's just as heavy and just as thick. It's crazy.
Tommy, you mentioned FDG imaging. Can you tell us what that stands for?
I'm not that smart anymore. I can't, let me Google it real quick. It's hard to pronounce, and I don't want to be, I told you if I didn't know the answer to a question, I would tell you.
It looks like Mary Jo has put it in the chat.
All right, let me get there.
Okay.
I have to refresh my memory. I don't work in it, so.
Tommy, does fluorodeoxyglucose positron emission tomography sound familiar?
That is exactly what it is. So that's why I can't remember it. It's too damn long, and I would have to go back and read it for about 2 hours to reacclimate myself to the way it works. Let me see.
Does anyone have any other questions?
I haven't been involved in FDG PET scanning since I left Nebraska back in 2008.
Okay. Nope.
Okay, well, if there are no other questions, here we go. Michael is asking, this is the radiopharmaceutical used in PET scans. Oh, he's telling us that that's what that is. Radiopharmaceutical.
Yeah, it's a beta emitter.
Thank you, Michael. Okay, and then Michelle is saying that she has a lot of ongoing pain around the mastoid bone. I think she means, is ultrasound imaging something that might be used?
It depends. If it's a soft tissue mass on the outside of the bone, they would probably go with ultrasound. If it's not a soft tissue mass, they would most likely go to CT on the front end. And if that was inconclusive, they may even go to MR. But if you do mastoid work on MR, you have to have the right coils and parts because it's a very specific exam and you can't do it with just a traditional head coil.
Okay. Any other final questions?
Nope.
As Tommy said, he is willing to, answer your questions directly through email or. Carol says, hope they give you a lunch hour.
If you're an X-ray tech, you learn how to eat when you can. But my job is to make sure that you get access to the care you need, specific to imaging, that we take good care of you, I don't have a lot of rules as far as being a manager. Patient care is really important to me. And the reason I'm in healthcare is because I was exposed to it at an early age. My brother was diagnosed with acute lymphocytic leukemia in Nashville, Tennessee in 1967. He had a 13% chance of surviving at the time. My dad, fortunately, was a banker, so they moved us back to Memphis. St. Jude took care of him, and he's alive today. So a lot of summers that I spent in Memphis, I spent at St. Jude with my mother, with my brother. So I saw from an early age what really remarkable, patient-centered, focused healthcare was. But I've also seen the other side of it where it's terrible. So it matters to me. I don't have, like I said, don't have a lot of rules. I want people to come to work in a good mood. I want them to enjoy what they do, but most importantly, I want them to take really good care of the people that come to see us, because it does matter. What we do matters. What we put on film matters. What we put in front of a radiologist matters. It's literally a matter of life and death. And never take the exam for granted. So if we're not doing it the right way, I want to know about it. But I would say to a man and a woman on both campuses, they do as good a work as anywhere I've ever seen. And like I said, I've worked in some of the best places in the country. I would put our folks shoulder to shoulder against anybody in Portland or Seattle. They're that good.
Great.
Okay, great. Thank you for sharing that. Everybody's just thanking you in the chat. We will sign off now. I did put a link to a survey in the chat, but you will also receive that link in a follow-up email from Samaritan. So if you could give us your feedback, it helps us to make sure that these are as valuable to the community as possible. With that, thank you all for joining us. Enjoy the rest of your day. Thank you, Tommy.
Thank y'all. It was fun.